Economics has been called the science of getting the most out of life. To get the most health for the healthcare dollar, it pays to be well-versed in economics. I'm Andy Reynolds. Today on Quality Matters, a revealing look at what's really happening in the healthcare economy. To begin this economics education, I spoke with Sanjula Jain of Trilliant Health. Sanjula Jain, Chief Research Officer at Trilliant Health. Welcome to Quality Matters. We're glad you're here.
Thanks for having me, Andy.
We're speaking in December 2024, and I'm looking at one of my favorite reports all year, Trilliant's 2024 Trends Shaping the Health Economy. It is 164 pages, no photos, no fluff. You outline 8 macro trends, and throughout the 164 pages, there are secondary trends and 1, sometimes 4 charts or figures on each page. This is quite a piece of analysis. So my first question is, Sanjula, how did you do this?
Well, thank you for that. I'm a health economist by training, and I like to look at data-driven trends that define the health economy. I felt there needed to be a common language and source of truth that connected facts and figures on a range of topics that might seem like they're not related, but actually when you put them all together, I would hope that it would change all of our perspectives. It's basically, okay, who is providing healthcare? Where are Americans going to seek healthcare? What type of care are they getting? What prescriptions are they taking? So it's understanding what is the cost of care? What are their policy dynamics affecting how we're interacting with the healthcare system? We have an amazing team of data analysts who are always looking at the data real time to see are certain signals changing. We really try to block out the noise of what things we're reading are kind of telling us to think, but really trying to have a blank slate approach to how we look at the industry.
Your report mentions that costs cannot increase by more than 50% while demand is flat. This reality is unsustainable. Unpack that for us, please.
The U.S. health economy is at its breaking point. There's data in the report, but also everywhere you look, Americans' number one concern when it comes to healthcare is the cost of care, affordability. They're delaying care because of the cost. That is really bankrupting America. And then we don't see improvement in health outcomes. I could argue that it's unsustainable just based on the pure cost of care and how much that we're having to pay. But it's also unsustainable when you factor in what are you getting for the dollars that we are putting into the healthcare system? And I would argue really not much when you think about health outcomes.
The focus of your report is value. My simple equation for value is that value equals quality divided by cost. Is that a smart way to think about value?
I would encourage folks to think about value for money, which is more nuanced. We all know what value for money is in our day-to-day lives. Let's just take hotels, for example. Marriott is a known brand. You can make a reservation at a Courtyard Marriott, and you can make a reservation at Ritz-Carlton, both part of the Marriott umbrella. You know what you're paying for. I'm not going to get the same amenities at the Courtyard as I would the Ritz, but there's a difference in the cost. Same thing in the car industry. There's a difference between the Honda Accord or Lamborghini. The same thing should apply in healthcare. Value is in the eye of the beholder. Everybody has a different value equation. The asset can be quality and cost, but for some people, convenience is a component. At the end of the day, are you getting the value that you ascribe for the money that you are paying? That's really what it comes down to.
You say in the report, value for money is not to be confused with value-based care. What do you mean?
Value for money is the ultimate consumer of the service is going to determine that value based off what they are paying. Value-based payment, it's different because value-based payment is ultimately a reimbursement scheme that doesn't change the total cost of care. Value-based payment is really a policy scheme focused at the provider level, which doesn't even affect the patient or consumer. It's one pool of dollars that is being reallocated. Providers are just reallocating those dollars, not actually reducing the total cost of care. Who is benefiting doesn't actually translate down to the patient or the consumer.
Okay, so I'm getting from you that there are big differences between terms that sound like they could be mistaken as synonyms. So I'd like to read off these terms to you and get your quick evaluation on each of them. Value for money. How do you rate it?
Great idea.
Okay. Value-based care.
A failing idea.
Value-based payment.
failing idea.
Okay, so for those of you keeping score at home, we have 2 fails and 1 great idea from Sanjula. Value-based payment, fail. Value-based care, fail. Value for money, Sanjula likes that idea. Sanjula, these ideas sound so similar, so how should we think about the differences?
It comes down to the level at which the payment incentive is operating. In value-based payment, the incentives, it's operating at the provider level. You're dealing with payment from the government to hospitals and physicians. It's just a reallocation of money. Medicare spending is not decreasing as a result of these value-based payment incentives. Value for money is, like we talked about it with hotels and cars, affects the consumer of the services, not the provider. Value for money is more of how we operate every day in our lives, where the providers have to uphold the value the consumer is asking for. Value-based payment ultimately doesn't reach the consumer of that service.
Got it. Thank you for teasing that apart. Let's get into another area where terms that sound similar mean different things. Your report draws a distinction between optimizing value and maximizing value. What's the difference?
Let me give you an outside healthcare example. Think about Costco. They are optimizing value. They leave money on the table for individual goods in some instances. They're not thinking about every single interaction to increase profit. There is a trust when you go into Costco. No matter what you are looking at, it's going to be the best rate possible, competitive price or lowest price. They have a set rate of a margin that they will charge. So a tray of muffins, let's say they purchase that for $2, and that set margin says, okay, we're going to charge $5. Even if they know they could get away by selling it for $7, they say no. Costco policy is we're going to cap it. They are optimizing value, knowing that even though we could make more profit, they are not breaking trust. There is that loyalty with the customer. The result is that consumers probably end up buying more goods. So the incremental revenue they lost on muffins, the $2 additional they could have charged, ends up balancing out all the other things that the shopper ends up buying.
Okay, so Costco's an example of a value optimizer. What's happening in healthcare?
The health economy is focused on maximizing value. Maximizing value is maximizing revenue. I will pick on my pharma friends. If pharma rethought how to get Americans using generic drugs, they may see a decline to their total revenue, but in the long run, that's delivering more value to their target customer, which can realize different forms of revenue or loyalty in other ways. That's kind of the difference between optimizing and maximizing, where right now the health economy does every single thing they can do to maximize that revenue. How can I get the most reimbursement based on this policy scheme? How can I bill for the most things? It should be more about the core things I need to deliver, almost independent of what I could bill for. That's a big factor in making the health economy so unsustainable.
A major conclusion of your report is that stakeholders who focus on value optimization will have a competitive advantage. How so?
There's more people competing for a shrinking pool of profitable patients. How you compete in the negative sum game is you lose less. Everyone has to give up something, or we're going to lose a little something than what they're used to having 10, 20 years ago. You basically have to figure out how can you optimize within that. If you are a health plan or a provider group, your ultimate customer is the employer. You have to think about, how do I deliver more value than my competition? You're going to have to start doing things like the Costco model to stand out and compete, because there's competitive pressures we haven't seen before.
You mentioned healthcare as a negative sum game. My memory is the negative sum game is where everyone loses, and the prize is worth less than all of the inputs or the costs invested. Are things really that dire?
Yeah, I do think it's that bad. I don't think the industry has woken up to what is happening at a macro level. When you get outside your silos and look at how this is playing out, it's not promising. Excess mortality, cost of care, health status. It's not just staying bad. Things are getting worse. If I could leave folks one thing, it would just be that this point in time is unlike no other. This should be a wake-up call
You mentioned in the report that the future of the health economy belongs to those who prioritize optimizing value for their customers. Can you tell me more about what that would look like?
Think about the airline industry and retailing, large consumer brands, like they're constantly having to think about value, and there ends up being fewer players. So it's going to be interesting to see who is up for competing. Those who don't figure out a way to change their approach are going to be at a disadvantage. Nobody wants to say you are going to fail. No one likes to talk about the bad things coming our way, but I view it as a warning. Hopefully some players are starting to think differently and understand nuances of their markets and how they can optimize, because the optimization equation is going to look different for everybody. There is no choice but to compete. It already is a negative sum game. So by that definition, everyone's losing. I spend a lot of time with executive organizations, and I always ask, raise your hand if things are going well for you. And very rarely do people enthusiastically raise their hand. Things are tough. And I think that is just the tip of the iceberg.
The thing about an iceberg is there's more to it than people can see. So let's talk about other things that people might not be seeing. What do most people in healthcare not know, or what do they get wrong about value?
They assume there's a correlation between quality and cost of care. And we're not seeing that actually play out. We see that price is random. What payers are paying providers cannot be explained. It's been this black box and it's unexplainable. That is one of the biggest misunderstandings.
At one point in your report, you call out that HHS, the Department of Health and Human Services, has experimented with value-based care for more than a decade with limited reductions in spending or improvements in quality. Walk us through that, please.
We've got individual payment models, got MIPS, we've got ACO REACH year over year, but is it working? And a lot of the narrative in Washington is, oh, well, participation is slowly growing. We're seeing a greater percent of payments flowing through these models. Well, that's a very micro view. When you zoom out and look at what were the goals of value-based payment, it was how do we bend the cost curve without sacrificing quality and, if anything, improve quality. Where you look at the amount of money we have put into CMMI models around value-based payment, how much we've spent to set up these programs, participate in these programs, reporting that's revolved around it, the math doesn't add up. We're spending close to $13 billion in many of these programs and have only gotten about arguably $3 billion in savings. Value-based payment had great intent. It's in theory sounds like a great policy, but it's not just 1 or 2 years of pilot. Like, we're a decade into this. And so the question becomes, what is going to make it work going forward? So to me, it all comes down to math. We focus on, if we focus on improving implementation. But to me, these are all excuses and trying to rationalize. But at what point do we say as a nation, hey, something is not working, let's try something different?
What do you think those of us in healthcare quality measurement should do differently?
I would encourage quality leaders to think about the intersection of quality and price. The policy passed pretty recently called transparency in coverage, which now requires health plans to post their negotiated rates. This is the first time where there is no longer the black box or information asymmetry from the payer perspective. The punchline is, now we know what United versus Anthem is paying for that hip and knee procedure. When you plot the intersection of mortality against those rates, you see there is no relationship. Organizations are getting paid 3, 4, 5x the amount as another provider, but their mortality rates are higher than a provider that's getting paid less. Some eye-opening plots in the report expose this. They're blinded dots, but if you knew the names of some of those dots, they are name brand institutions in many cases. I'm not saying that everyone's to pay the same amount. You could pay more for a medical procedure, but that quality needs to stack up. So in a nutshell, let's zoom out, take a higher order view of quality. Let's look at mortality and put that against rate. We're not doing well on mortality, and we're the United States of America. The I think that's pretty shameful, given all the innovation and tools and knowledge and intellectual capital that we have. We can do so much better. And ultimately think about how do we deliver more value to the American population.
The word quality appears in your report 62 times, so very frequently.
Thank you for counting that. I had not done that.
Yes, and on page 51, you say that quality reporting is expensive. What do you see regarding what people pay for quality measurement versus what people get from quality measurement?
I think it comes down to inputs and outputs. Are we getting enough output? You could argue that output is a reduction in mortality. It could be a reduction in total cost of care, general improvement in health status. The data doesn't show that we moved the needle on those metrics. For the money and time and resources we're putting into it, is it even paying off? Or should we relook at this? It's not to say that quality reporting is not important. It's to say, how can we better adjust and use our resources? We have this tendency in this industry to just keep going versus kind of pausing and reflecting, saying, okay, are we actually introducing more complexity? We haven't really moved the needle on mortality. Cost is going up. Well, something has to change. Relative to what we're spending, the ROI doesn't appear to be there at that health economy level. Maybe we should think about a different solution.
To discuss what a different solution might be, I spoke with someone at NCQA who is a fan of Sanjula's work.
Hi, my name is Megan Malone-Moses. I am the Director of Market Insights at NCQA. Sanjula noted quality doesn't correlate with cost. And this idea about government innovation and regulation not producing a value. There's an interesting slide in the report on the burden of quality measurement. I did some calculations based on that slide. The slide showed the burden of measuring quality at a single academic medical center. 16% of the measures reported were electronic, but that translated to less than 1% of the personnel costs to collect it. That highlights the potential for things like moving towards digital quality measures to reduce the burden and some costs.
That's interesting, Megan. It sounds like you're disagreeing a little with what Sanjula told us. What are you getting at?
Digital quality measurement and making sure that providers and payers to align incentives based on quality can reduce the overall cost. There seems to be inertia within organizations to make changes that will benefit them because of fear of that initial lift. It's costly to move towards digital quality measures, but they're ignoring the savings and the administrative burden reduction and the benefits to the patients, the providers, and the other stakeholders that are waiting on the other side of this. So at NCQA, we're digitizing our measures. We're developing automated data validation in order to address some of these current burdens that are costly and manually intensive. That can benefit multiple use cases and not just quality measurement.
Sanjula, let's give you the last word. What are you optimistic about as we look ahead to 2025 and beyond?
Don't underestimate the power of the employer and the American voter or individual. They will have larger voices. That's going to change how we think about some of the inputs into our future policies, and policy plays an important role, but I'm optimistic that there'll be other catalysts from those other players that may force the value discussion in a way that we haven't had to deal with in the past.
That sounds good. Maybe we'll follow up with you in a year or so to see how that's going. Sanjula Jain, Chief Research Officer at Trilliant Health, thank you for speaking with us on Quality Matters.
Thank you.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.